Hello, my name is Eddie Sheets, and this is my cardiovascular and pulmonary assessment. I have Jacoby here that's going to help me today. We are at home. We don't have a gurney at bed. It's going to be setting up on the table here. First thing we do is we gather our equipment, provide privacy. We'd identify our patient. We'd wash our hands. Jacoby, we're going to do an assessment today on your heart and on your lungs. So the first thing that I would do is just do a physical inspection, make sure symmetry, muscle tone, shoulders, his rib cage, everything, looked like it was in normal. Signs of respiratory distress, anything out of order. If he was having respiratory distress, which he's not, the use of accessory muscles, that type of stuff, everything seems to be pretty much in check. So the first thing I would do is have you go ahead and turn your head to the left. We're going to look at the external jugular vein. We're going to find the internal jugular vein, and we're looking for the jugular vein pressure. Typically it's going to be in this area here. His is about right there. At that point we would take a flat edge from the point of that, measure it to the sternal notch, and anything under 3 centimeters is considered normal. If it's higher than that, you might raise the bed up and have them go that way. Next, I would check his carotid artery. You want to avoid the upper part. You want to do one side at a time and palpate, feel in for carotid pulse, do on both sides. And then you would want to auscultate and listen for breweries, anything like that. You should have a kind of an upflow. If you have a murmur, you want to pay special attention to his heart, because the murmur could echo up through his carotid, and his sound good. So at this point, what I would do with his carotid arteries, I'd move down. We want to check the positions of his heart. The way I remember this is I use all physicians take money. You want to go to your second intercostal on your right here, and this is your aortic. Then you go to, that's your all physicians, your pulmonic, second intercostal, the left side of the sternum. And then you're going to go to your third, fourth, and fifth, which is your Erb's point right here. And then that would be takes your tricuspid, and then your mitral valve, the money down here, kind of mid clavicle. Here it'd be your maximum point of impulse, or your apical pulse right here. We'll do that both by using the diaphragm first. Second intercostal, aortic. Listening for murmurs, your rhythms. I also listen for my S1, S2. I've always learned lub dub, lub dub, lub dub. Going to the second intercostal on the other side, pulmonic. Your third, fourth, and fifth. Kind of work your way down. It's your tricuspid. And then you want to go underneath, mid-clavicle. This is your apical. At this point, I would count my heart rate. I would do a full 60 seconds. Be your apical heart rate. During this assessment, we're just going to play like we done the 60 seconds. Then you want to palpate the same positions that you did. You're looking for heaves, lifts. Sometimes in frail or little people you can feel. it should be just like it just coming up to tap your finger. It really shouldn't be lifting your finger up. It should just be kind of like a tap on your finger. If you can't get it that way, you can have them lay on their left side, and that kind of makes that maximum point more visible. And we won't do that in this assessment. At that point, I would go ahead and we're looking at the lung fields like we did. We count our respiratory rates in the beginning. Sometimes I do my respiratory rates when I'm doing the radial pulse, kind of get some sidetracked on what I'm doing here, and I can watch the regular. I don't always just say, hey, I'm counting your rates. I kind of do it at a point. Usually I do it when I'm doing the radial pulse. I kind of do both. Pulse, I do kind of both. So on their lung fields, what we want to do is we want to go above the clavicle, both sides, and kind of work our way down. Our bronchioles, our upper lobes, and then we go posterior and we'll work on the medial and lower lobes. So we're listening for different sounds, wheezes, coarse, anything that's abnormal, crackles, fine crackles, coarse crackles, anything like that that would be abnormal, that there might be a presence of fluid or any kind of consolidation that's there. So one other thing that I'd like to do is the tactile perimetus, and that's where you just take, now you say 99, you want to go in between the rib and then the intercostal spaces, say 99.
99.
99.
99. 99. 99.
At that point, you should feel the vibrations of the 99. With the air up there, it should be pretty clear. If you get a dull sound, there could be consolidation there, and that would be an area of concern. You'd also want to palpate on these before you go. You want to feel for masses, tenderness, that type stuff. And once you do that, you can listen to both sides. I'm going to put my stethoscope. One other thing before I go to the lungs, I would change to the bell and listen to my landmarks again. Second intercostal, second intercostal, third, fourth, fifth, Erb's point, then mid-clavicular, overture. Then we go to the lung sounds. We're going to go both sides. You're looking for symmetry. You want to work evenly on both sides. Deep breath. Deep breath. Deep breath. Now have you say 99,
99.
99,
99.
99,
99.
99,
99.
99,
99.
99.
99.
Then I have you whisper 1, 2, 3. Whisper 1, 2, 3. Whisper 1, 2, 3. So on the whisper test and the you do the whisper test and the bronchophony,